Welcome to Part 5 in this educational series. This program is focused on the entire spiritual care team, including physicians, nurses, the clinic manager, and other practice staff. Special attention, though, is being paid to the role of the chaplain on the team. First, I describe the common goals and purposes of the spiritual care team. Next, I review material covered in parts 1 through 4. I then focus on the role of the chaplain or pastoral counselor. This includes the training of the chaplain, what the chaplain does, and what the chaplain needs from and gives to the spiritual care team. I follow this with a discussion of the role of the social worker, particularly in hospital settings. Our objective here is to describe how the spiritual care team, whether operating in an outpatient or an inpatient environment, can work effectively together. First, what are the goals of the spiritual care team? Number 1, identify patients' spiritual needs related to medical illness. Number 2, address patients' spiritual needs. Number 3, follow up later to ensure that spiritual needs have been adequately addressed. Number 4, create an atmosphere where patients feel comfortable talking about their spiritual needs with the physician and other team members. Number 5, address the whole person needs of team members related to providing patient care and provide whole person medical care, including spiritual care, to all patients. I now review the material covered in the initial 4 parts of this educational series, starting out with what we mean by integrating spirituality into patient care. Basically, integrating spirituality involves 4 activities. Number 1, first, the physician conducts a brief spiritual assessment to identify spiritual needs related to medical care. Second, the spiritual care coordinator arranges for other spiritual care team members to address the spiritual needs identified by the physician. Third, efforts are made to create an atmosphere where patients feel comfortable talking about spiritual needs with the physician and other team members. And finally, spiritual care is provided to all patients as part of whole person health care. Why should health professionals take the time to assess and address the spiritual needs of patients? Here are 7 reasons. First, many patients have spiritual needs related to illness, and addressing those needs affects satisfaction with care, quality of life, and interestingly, may also reduce healthcare costs. Number 2, religious beliefs influence coping with illness and may affect a patient's emotional state and their motivation towards recovery. Number 3, religious beliefs affect important health-related behaviors and likely influence medical outcomes. Number 4, religious beliefs influence medical decisions made by the patient, and the religious beliefs of the physician influence the medical decisions that he or she makes for the patient. Number 5, JCAHO standards of care require that providers respect patients' cultural and spiritual beliefs, and assessment is the only way to know what those beliefs are. Number 6, support from a religious community may increase patient monitoring and improve compliance with treatment. Finally, addressing spiritual issues may benefit the health professional by providing intrinsic rewards that are associated with delivering whole person health care. There is also scientific rationale for assessing and addressing patients' spiritual needs. I will quickly review some of that research here. However, for a more detailed examination of these studies, viewers are encouraged to watch Part 2 in this educational series. I begin with mental health and then move on to social health, health behaviors, and physical health. This summary is based on a systematic review of the literature published in the Handbook of Religion and Health. In some areas of the United States and elsewhere in the world, up to 90% of medical patients use religion to cope. Research indicates that the overwhelming majority of these patients report that religion helps them. Religious beliefs are commonly used to endure the distress caused by health problems. Religious beliefs give meaning to illness, promote hope for recovery, and provide behaviors that make the individual feel more in control, such as prayer. Beliefs of this kind have been repeatedly linked with better mental health in medical patients. How, though, is religion related to health more generally? With regard to mental and social health, religious involvement is related to less depression in over 60% of 444 quantitative studies, greater well-being and happiness in nearly 80% of over 300 studies, greater meaning and purpose in over 90% of studies, greater hope and optimism in over 75% of over 70 studies. Because they convey greater meaning, purpose, and hope, religious beliefs and activities are related to less suicide, fewer suicidal attempts, and more negative attitudes towards suicide in 75% of over 140 studies. Religious involvement is also related to less alcohol and drug use or abuse in over 85% of nearly 300 studies, and greater social support, greater marital stability, and more pro-social behaviors in more than 80% of over 250 studies. What about health behaviors, such as exercise, diet, cigarette smoking, sexual activity, and weight control? These behaviors are responsible for nearly 80% of all chronic medical illness. The research shows that religious persons are more likely to exercise or be physically active in nearly 70% of more than 36 studies, eat a better diet in over 60% of nearly 24 studies, have lower cholesterol in over 50% of studies, participate in less extramarital sex in over 85% of nearly 100 studies, and less likely to smoke cigarettes in 90% of over 130 studies. Unfortunately, the more religious had lower weight in only 20% of studies and were heavier than non-religious persons in 40% of studies. Despite being heavier on average, though, religious persons have better physical health than non-religious persons in the majority of studies so far. This includes better immune function in over 50% of 24 studies, better endocrine function in nearly 75% of 31 studies, better cardiovascular functions in close to 70% of 24 studies, less coronary heart disease in nearly 2/3 of nearly 20 studies, lower blood pressure in nearly 60% of 63 studies, less cancer or a better prognosis in more than half of 24 studies, and greater longevity overall in 68% of over 120 studies, including over 75% of the best designed studies. Finally, research indicates that spiritual needs are widespread among medical patients, and when these needs are not addressed by the medical team, this reduces the patient's quality of life and satisfaction with care, and can double or triple healthcare costs. Furthermore, randomized clinical trials show that when physicians conduct a spiritual assessment, this results in a better doctor-patient relationship, better compliance with clinic visits, lower depression in the patient, and a greater functional well-being. In conclusion, based on this review of the research, number one, religion is often used to cope with stress in general and medical illness in particular. Number two, religious or spiritual involvement is associated with greater well-being, less emotional disorder, less substance abuse, greater social support, and better health behaviors. Number 3, religiosity is related to less physical illness, better medical outcomes, and greater longevity overall. Number 4, spiritual needs are widespread in medical settings, especially in those with serious, life-threatening disease. Number 5, assessing and addressing patients' spiritual needs is related to greater satisfaction with care, better quality of life, less depression, fewer unnecessary health services, better functioning, and a better doctor-patient relationship. Number 6, much research is now being done to better understand relationships between religion and health, determine the underlying biological mechanisms involved, and developing new interventions that harness these effects. And finally, given the results of this research, there is every reason for health professionals to assess and address the spiritual needs of patients. Therefore, what are we expecting of the physician? This is important for other team members to know about, since a major task of the team is to support the work of the physician. We are asking physicians to do the following. Number 1, conduct a brief spiritual assessment in order to identify spiritual needs. Number 2, arrange for someone to address those needs. Number 3, follow up to ensure that spiritual needs are met. And number 4, be willing to discuss this subject with patients while appreciating the health benefits of doing so. What do I mean by spiritual assessment? The spiritual assessment involves asking a few simple questions to identify spiritual needs related to medical illness. The purpose of the spiritual assessment done by the physician is to, number 1, make the physician aware of the patient's religious background. Number 2, determine if the patient has religious or spiritual support. Number 3, identify beliefs that might influence medical decisions and affect compliance with medical care. Number 4, identify unmet spiritual needs related to medical illness. Number 5, determine if engagement of the spiritual care team is necessary. And number 6, create an atmosphere where the patient feels comfortable talking with their physician about spiritual needs affecting medical care. Assuming the receptionist has recorded the patient's religious affiliation in the electronic medical record and the physician has access to it, the physician's spiritual assessment consists of the following 3 questions. Number 1, do you have a religious or spiritual support system to help you in times of need? Number 2, do you have any religious beliefs that might influence your medical decisions? And number 3, do you have any other spiritual concerns that you would like someone to address? The physician will then document the patient's responses in the electronic medical record. If spiritual needs are identified, the physician will alert the spiritual care coordinator so that arrangements can be made to address those needs. Finally, there should be follow-up down the road to determine if spiritual needs have been adequately addressed. The spiritual care team will assist in this regard, although the physician is responsible for ensuring that such follow-up occurs. This is the minimum requirement that we are requesting of physicians.
Addressing spiritual needs begins with a spiritual assessment. Spiritual assessment is asking 3 questions. The first question really goes to the heart of the matter. Do you have a faith-based support system to help you in times of need?
Yes.
The response to that question gives me a good idea on where the patient is connected. If they have a community of faith, if they have friends, other people that can be involved in their care when they have needs. The second question is very helpful as a practitioner. Do you have any religious beliefs that might influence your medical decisions?
No.
It really helps to know that up front. We need to talk about those things before we're in a crisis. When I take a spiritual assessment, I'm entering it directly into the electronic medical record. The benefits of having it in the medical record are, number 1, that you don't forget it from patient to patient. It's also helpful if you're taking care of somebody else's patient and there's a need. Do you have any other spiritual concerns you'd like someone to address? The third open-ended question opens up the opportunity for us to talk with them further, maybe to refer them up the line to the spiritual coordinator or to the chaplain. Taking a spiritual assessment is not necessary for every patient every time, but there are some times when it's very convenient. I've found that physical exams are a great time to bring this up. Additionally, when the patient's struggling with health issues, they often want to discuss this, and it's really appropriate to talk to them about it at that time.
The spiritual assessment is not a one-time event. Whenever there is a significant change in the patient's condition, the physician will want to check whether any new spiritual needs have arisen that the patient needs help with. Who does the spiritual assessment by the physician apply to? In other words, what types of patients need a spiritual assessment by the physician? 5 categories of patients where a spiritual assessment is indicated are: number 1, patients with serious, life-threatening conditions. Number 2, patients with chronic disabling medical illness. Number 3, patients with depression or significant anxiety. Number 4, patients newly admitted to the hospital or to a nursing home. And number 5, patients being seen for a well-patient exam when time is available to address social issues. In contrast, who doesn't typically need a spiritual assessment? Number 1, patients seen for an acute problem without long-term implications, such as an upper respiratory infection, minor surgical procedure, routine pelvic exam, or some other specific well-defined condition. Number 2, patients seen for follow-up of a time-limited problem where there is no significant disability or challenges to coping. Number 3, children, teenagers, or young adults without chronic illness, life-threatening conditions, or disabling serious medical problems. And number 4, patients who are not religious or spiritual, and this area is not relevant to them. Not all patients need a spiritual assessment by the physician. However, spiritual care must be provided to all patients as part of whole person medicine.
Research shows that 3/4 of the patients who come into a primary care doctor's practice would appreciate a conversation with their doctor about spiritual issues. It's our intent to address those with very simple questions that open the door for patients to express those concerns and allow doctors to address them.
Providing patients with a spiritual assessment is really something that we should be doing. There's data to say that's true. We need to understand our patients. We need to meet their needs both physically as well as emotionally and spiritually. Generally, when doing the spiritual assessment, it's a few simple questions and then we move on. Now, there are times that patients have heartfelt needs, and for that I can access my spiritual care team, which is very helpful.
Addressing the spiritual side of a patient's concern puts one more piece into the puzzle of restoring them to health.
So what do we mean by spiritual care? Although assessing and addressing spiritual needs is part of it, spiritual care goes far beyond that. The way that ordinary health care is provided by the physician and other team members can be spiritual. By that I mean recognizing the sacred nature of the person being cared for and the holy obligation and privilege that health professionals have. More specifically, this means, number 1, providing care with respect for the individual patient, a person with a unique life story. Number 2, inquiring about how the patient wishes to be cared for, rather than providing the same care in the same way to everyone. Number 3, providing care in a kind and gentle manner. Number 4, providing care in a competent manner. And finally, number 5, taking extra time with patients who really need it. Spiritual care is the heart of what whole person care is all about and has the potential to bring vitality back into the patient and into the practice of health care. However, it is not easy. Indeed, there are many barriers that prevent the delivery of spiritual care. These include lack of time. Physicians have very little time to assess and address the spiritual needs of patients. Discomfort. Many health professionals are not comfortable addressing this topic. Fear of making the patient uncomfortable, particularly if he or she is not religious or spiritual. Spirituality is not important to the health professional. This topic is too personal, or there is no private space to discuss these issues. The belief that spiritual care is done better by others. The belief that patients don't want spiritual care. Concern that the power inequality between patient and physician might lead to coercion. Religious beliefs of the health professional differ from those of the patient. The belief that spiritual care is not part of the health professional's role. All of these barriers can be overcome through training and practice. It's the practice part that will make the health professional comfortable and fluent in spiritual care. When the physical, emotional, social, and spiritual needs of health professionals are not met, the ability to provide spiritual care and whole person compassionate care will suffer. In order to provide whole person care, the health professional needs to be a whole person. Health professionals have physical, emotional, social, and spiritual needs that must be met for them to be fully functional as a whole person in a clinical setting. As I noted earlier, integrating spirituality into patient care can't be done by the physician alone. For that reason, we are surrounding the physician with a spiritual care team made up of health professionals who will provide practical assistance, emotional and spiritual support to the physician and each other. There are, however, also boundaries to providing spiritual care. Sometimes health professionals go beyond their expertise and do things that are neither sensible nor ethically justifiable. Here are 5 don'ts, most of which are pretty obvious. Number 1, don't prescribe religion to non-religious patients. If religion is good for health, you might think maybe non-believers should be encouraged to become religious. Not a good idea. Number 2, don't force a spiritual assessment if the patient is not religious. In that case, quickly switch to asking about what gives life meaning and purpose in the context of illness and how this can be supported. Number 3, don't pray with the patient before doing a spiritual assessment and unless the patient asks, or be ready for a lawsuit. While more than 2/3 to 3/4 of patients would like to pray with the health professional and deeply appreciate the offer, others do not. Number 4, don't spiritually counsel patients. Instead, always refer to trained professional chaplains or pastoral counselors. The only exceptions might be if the health professional has pastoral care training or if addressing spiritual issues is urgent and the patient refuses pastoral care or pastoral care is not available. Number 5, don't do any activity that is not patient-centered and patient-directed. Remember, it's about the patient, not the health professional.
We all know that office visits are really very limited time to spend with the patient. If there is an issue that can't be handled, I can send it to my office manager. Also, we have the chaplain that we can call, that we can refer the patient to for more complicated cases. This core group of people of which I am a part is what we call the spiritual care team. Having a team allows us to be more effective. Each person has a different skill that they bring to the table. That's extremely helpful when you're dealing with patients because we know that each patient is different.
Now I'd like to say a few words about spiritual care from a team perspective. Although the physician has the responsibility to assess and document spiritual needs, he or she is not alone. The physician is surrounded and supported by the spiritual care team, whose responsibility is to address the spiritual needs of patients and ensure adequate follow-up. So, who are the members of the spiritual care team and what are their roles? First is the physician, whose role is to assess and document the patient's spiritual needs. Next is the spiritual care coordinator, who obtains information from the physician's assessment, coordinates the addressing of spiritual needs, prepares the patient for pastoral care referral, and provides spiritual support to other team members. Next is the chaplain or pastoral counselor, whose responsibilities I will outline in just a minute. In hospital inpatient settings, the social worker will work with the chaplain to develop a spiritual care plan and arrange for long-term follow-up and feedback to the team. Finally, there is the receptionist, whose responsibility is to record the patient's religious affiliation in the medical record.
As a member of our spiritual care team, my role as a physician is first of all to engage the patient, make them feel comfortable so they will be able to open up about their spiritual needs and beliefs. There are times when they don't have support and they need support and they don't know where to turn. So our spiritual care team allows me to connect them with my MA, who is our spiritual care coordinator, and if needed, to a chaplain at the hospital. This network that we have formed has allowed us to meet the spiritual needs of patients that we did not have the manpower or time to do in the past.
Well, you know, days get busy. We have a lot of patients to see, and sometimes we have to move on to the next patient. And so in reality, we have to work as a team, and I'm thankful that I have a team to fall back on.
The spiritual care team has been proven to have benefits to patients. There's quite a bit of data saying that this is important in terms of healing, it's important in terms of patient care, and therefore we should really incorporate it into our practice.
An important part of the work that we do together as a team is to have a monthly meeting. I like to think of it as a spiritual care team huddle.
That gives us a time to talk about patients that have been referred through the system, to know that they have followed up, to take care of any concerns that are ongoing, and to know that in fact patients are being taken care of.
Now I'd like to focus on the responsibilities of the chaplain or pastoral counselor. I will examine A, the unique role of the chaplain, B, the training of the chaplain, C, what a chaplain needs from the team with a referral, D, what the chaplain provides the team in response to the referral, and E, how to fully integrate the chaplain as part of the healthcare team. First, what is the role of the chaplain? The chaplain plays many roles, but there is one that is unique to this health professional. The chaplain is the only person on the spiritual care team trained to address spiritual needs. After receiving a referral, the chaplain will do a comprehensive spiritual assessment, which is quite different from the physician's brief screening assessment. The chaplain will clarify spiritual needs that are present and then will develop a spiritual care plan to address those needs. The chaplain will work with the social worker, if available, to implement the spiritual care plan after discharge from the hospital or from the clinic. He or she will also follow up to ensure that spiritual needs are met and will provide feedback to the team. Finally, the chaplain will work with the spiritual care coordinator to address the spiritual needs of team members that are related to patient care.
I think entering a person's story brings healing because you're able to connect with that person. All of us share a common story. Every human being is seeking that connectedness with each other, and we can be better people because we come alongside another human being and we can relate to them at a deeper level.
I think the chaplain has a key role in a healthcare setting. The chaplain is a specialist. He's a pastor. He's well trained in how to meet people's spiritual needs. When I can refer to a spiritual specialist, it's great to have him on our team. There's been so many times when people have said that the chaplain coming to visit them just meant so much. Just knowing that someone is there that will pray with you, pray for you, and watch over you, it really makes a difference.
An important part of chaplaincy is listening. It helps them to hear what they're really feeling, and it gives them an interaction with somebody who cares.
As a chaplain, I have the great privilege to be a counselor, a sounding board, a resource to our staff and our patients.
We have to have compassion, we have to have a good listening ear. We also have to respect where they are in their faith journey and the faith background that they bring with them.
She's a great resource when we need something beyond what we can provide in our office. She can deal with the more complex issues, things that might take more time or be more challenging.
When I get a referral from the spiritual care coordinator, one of the first things that I do is get that contact information and then make a phone call and then to try to assess what is their spiritual need and how can I help meet that. Then I like to sort of close the loop by calling the spiritual care coordinator or perhaps speaking with a physician and talking to them about what was the content of our meeting, what was the outcome, and then what were the recommendations that I made to the patient.
We want to make sure that there's a continuity of care going beyond our walls. So when that patient leaves, we want to make sure that they still have the best care possible.
Chaplains have a connection with local churches, local ministers, local counselors, good people that they can connect with on a regular basis.
As a chaplain here, I can also model what it looks like to be somebody who is kind, caring, and compassionate.
What is the training of the board-certified chaplain? To become a board-certified chaplain, a person must complete a 4-year college degree, a 3-year master's degree in divinity, and between 1 and 4 years of clinical pastoral education in the hospital with a minimum of 1,625 hours of clinical supervision. He or she must then obtain a letter of endorsement from their denomination, successfully pass a written board exam, and complete a personal interview by the chaplain organization that's certifying them. After that, he or she must complete 2,000 hours or 1 year of experience prior to actual certification. After certification, chaplains need 50 hours of approved continuing education each year in order to remain board certified. Thus, board certified healthcare chaplains are well trained to do the work that they do. Pastoral counselors have similar training requirements. After an interfaith chaplain receives a referral and sees a patient, what exactly does he or she do? Spiritual care team members need to know what the chaplain might do because they will have to explain this to the patient when a referral is made. I've divided the activities of the chaplain here into assessment and intervention. First, the chaplain does a spiritual assessment to identify and clarify spiritual needs. This assessment is very different from the one that the physician does. The spiritual assessment that the chaplain does will differ depending on their individual style. Generally, though, the chaplain will make contact with the patient and spend time forming a relationship. During this time, the chaplain learns the spiritual language of the patient, which may or may not be religious. Much of the assessment will be spent listening to the patient talk about his or her struggles. No advice or spiritual counsel is usually offered at that time. This is also called the ministry of presence. After this, the chaplain may ask questions about the patient's religious or spiritual background and inquire about positive and negative experiences with religion. When the assessment has been completed, the chaplain will then develop a spiritual care plan to address the spiritual needs identified. The chaplain will then perform one or more specific interventions. Note that the ministry of presence, which involves simply sitting with the patient and listening, is a powerful intervention by itself. The chaplain may or may not pray with the patient, depending on the patient's preference. The chaplain may or may not read a holy scripture related to the patient's illness, again depending on the patient's preference. The chaplain may or may not provide spiritual advice, depending on the patient's request and on the patient's readiness for such advice. The chaplain may provide religious resources to the patient, as requested, such as spiritual reading material, prayer beads, a prayer rug, and so forth. The chaplain may contact the patient's clergy or mobilize the patient's faith community for support, after, of course, obtaining explicit consent from the patient. All of this activity is highly patient-centered and focused on the patient's particular religious tradition or humanistic worldview. Finally, the chaplain will recontact the patient at some future time to get follow-up on how effective the interventions were in addressing the patient's spiritual needs. What are some other activities of the chaplain? The chaplain may listen to, counsel, pray, or provide spiritual and emotional support to family members. The chaplain may do the same for other members of the spiritual care team. In hospital settings, the chaplain may hold chapel services and administer sacraments or perform other rituals at the bedside. The chaplain may also serve on the ethics committees or institutional review board of the hospital. Finally, the chaplain works with community clergy who may be trained to fill in for the chaplain during emergencies or during situations when the chaplain is absent. In a survey of 1,591 patients at the Mayo Clinic, researchers found that 70% of hospitalized patients wanted to see a chaplain, but only 43% were visited by a chaplain, which is actually over double the national rate, which is only about 20%. The proportion of outpatients seen by a chaplain or pastoral counselor is probably in the single digits. When accepting a referral, what does the chaplain need from the spiritual care coordinator? Here's a list of information that would be helpful. Number 1, demographics, such as the age, gender, racial background, marital status, relevant family members, and where the patient lives. Number 2, religious denomination or background, if any, and prior religious involvement, if known. Number 3, medical diagnoses, including severity and prognosis. Number 4, who initiated the referral? In other words, the patient, family, physician, nurse, or social worker. Number 5, the reason for the referral. In other words, details on the particular spiritual need present, including what exactly the referring person wants from the chaplain. After completing a referral, what does the chaplain provide to the spiritual care team? Usually the following will be provided. Number 1, information on spiritual needs identified during the comprehensive chaplain assessment. Number 2, a spiritual care plan detailing the interventions performed or interventions planned to address those needs. Number 3, follow up on how effective spiritual interventions were in addressing spiritual needs. Number 4, input to the medical care plan to help craft it around the patient's spiritual and cultural beliefs, which is likely to enhance treatment compliance. Number 5, advice on how to negotiate sensitive ethical issues that other health professionals may have little experience with. And number 6, communicate with the patient's clergy and faith group to ensure that monitoring occurs in the community or to provide transportation to the clinic visit if necessary. Whether in an outpatient or an inpatient setting, the chaplain should be fully integrated into the healthcare team. As I indicated before, the chaplain or pastoral counselor is at the core of the spiritual care team because he or she is the only person fully trained to address spiritual needs. Consequently, the chaplain should be actively involved in hospital rounds and in discussions involving patients in the clinic. In hospital settings, the chaplain will often have a close relationship with the team social worker, and some hospitals have actually combined pastoral care and social services into a single department. The reason is that spiritual needs are often closely linked with social issues, and as a result, the social worker may provide important input into the spiritual care plan. In this regard, the social worker may, number 1, contact members of the patient's faith community for support after hospital discharge. Number 2, identify a local faith community for the patient if desired. Number 3, identify a pastoral counselor after discharge and set up appointments. Number 4, help the chaplain do follow-up to determine whether spiritual needs were effectively addressed. There are many other contributions that the social worker can make to the spiritual care team. These include, number 1, identifying spiritual needs during routine social assessment. However, this would never replace the physician's assessment. Number 2, arranging referral to the chaplain or pastoral counselor if the spiritual care coordinator is not available. Alternatively, the social worker may work with the spiritual care coordinator in arranging the referral. And finally, addressing simple spiritual needs if a chaplain is unavailable or is refused by the patient. This is only for simple spiritual needs, since most social workers are not trained to address this area.
Working together as a team is the right thing to do. Chaplains working with doctors, doctors working with spiritual care coordinators. Everyone is coming together for the good of the patient.
It's getting to know the people that are a part of my team. So it's about developing relationships.
For one thing, that means you're not alone. When you're dealing with a whole person, it's important to have different perspectives. Understanding where their spirituality comes from might help with certain treatment plans.
In concluding Part 5 in this educational series that focuses on the spiritual care team, I now summarize the key points involved in working together as a team to achieve a set of common goals. Each member of the team has a specific role to play, and if each person does their job, the following will be accomplished. Number 1, patient spiritual needs related to medical care will be identified and effectively addressed, and the physician's time will be minimized. Number 2, an atmosphere will be created where the patient and family feel free to discuss spiritual issues related to medical care. Number 3, each member of the team will feel emotionally and spiritually supported. And finally, whole person medical care, which includes spiritual care, will be delivered by all team members to every patient.
I think most of us went into medicine because we wanted to help people. That we can do well if we include not only their body, but their mind and their spirit.
All of us can bring hope. It is my joy, it is my privilege on a daily basis to bring that spirit of healing to our team so that they can then give it to others.
We may not be able to cure the person, but we can bring healing because healing is holistic.
I conclude this 5-part educational series by underscoring the main points we are trying to convey. First, there is every reason to assess and address spiritual needs related to medical care, based on common sense, good clinical practice, and a firm scientific rationale. Second, the physician is responsible for a brief spiritual assessment that is designed to identify spiritual needs and create an atmosphere where spiritual issues related to medical care can be discussed. Third, the rest of the spiritual care team, led by the spiritual care coordinator, supports the physician by ensuring that spiritual needs are effectively addressed. Fourth, the chaplain or pastoral counselor is at the core of the spiritual care team and is responsible for conducting a comprehensive spiritual assessment to clarify spiritual needs and develop a spiritual care plan to address them. Finally, in hospital settings, the social worker helps the chaplain to develop and implement the spiritual care plan and to arrange for follow-up to ensure that spiritual needs are met. For more information on how health professionals can assess and address the spiritual needs of patients, I suggest the book Spirituality in Patient Care, 3rd edition. There is also a lot of information available on our Duke Center's website at spiritualityandhealth.duke.edu.